I want to welcome our esteemed faculty, fellows, residents from India, from Nepal, Bhutan, Ghana, and Ethiopia to the HCP Cure Blindness virtual classroom. Many of you have already been on here, but there may be a few from India that have joined us today, especially from KEM Hospital. The HCP virtual classroom has been going on since November of 2022. We have covered AAO's BCSC book, from cornea to refractive surgery, glaucoma, and then retina. And now we are at Pediatric Ophthalmology and Strabismus. For those of you who took the retina test last time, we congratulate you. We are so thrilled that you all participated, and I would like to announce the winners of the retina test. There was a tie for first place, and that was from, can anyone guess which program came in first place? Addis Ababa University in Ethiopia. Congratulations. With that, I want to start our session number 1 with chapters 1 through 11 today from the AAO Pediatric Ophthalmology and Strabismus book 2022 to 2023. That's the latest book, and you all, those enrolled in the program, are all having access to this book. Let me introduce you to the first speaker. Those from Ghana very well know her name, and that is Professor Vera Essuman. She is the Associate Professor of Ophthalmology and Head of the Ophthalmology Unit at University of Ghana Medical School, University of Ghana. She's the head of the Pediatric Ophthalmology and Strabismus Unit at the Lions International Eye Center at Korle-Bu Teaching Hospital in Accra, Ghana. She has been a fellow of the Ghana College, an alumni of LV Prasad Eye Institute in Hyderabad, and her energy is infectious. It makes you want to go into pediatric ophthalmology. And so without further ado, Professor, I hand it over to you.
Thank you so much for the kind introduction. So these are the objectives from the book for the first 6 chapters. I've tried to move them around a bit, not going chronologically according to the chapters, but trying to tackle it from a point where it will make a bit of sense to all of us. So we will be looking at evaluation of the young child, which is the chapter 1. And I'm hoping that at the end of this discussion or interaction, each participant will be able to please describe the following: the techniques for evaluating young children, describe some visual development, normal vision development, and some milestones, be able to list some of them. Then we will touch a bit on assessment of vision as per age, and we will look at the motor anatomy and physiology of the extraocular muscles and of binocular vision, which will dovetail into amblyopia, its diagnosis and treatment. And then we will look at how to evaluate a patient with strabismus. So this then will be the outline. And as I said, I'm not going chronologically. I'm just I've rearranged them a bit as to how I'm going to proceed with that. So without wasting time, just let me say that I have no disclosures with any of the topics that I'm going to present and any of the things that I'll be talking about. And I'd like to, first of all, ask my audience, my colleagues, my younger colleagues, if they can type the answers to this. I know they have been handling children in their respective clinics. Can you tell us some of the challenges that you encounter, during evaluation of children generally? Okay, unable to keep them at the slit lamp, not able to sit still. Okay, I think it all comes into, and sometimes difficulty with accurate visual acuity. So I agree with you perfectly that children they lack comprehension as to what we are doing for them, and therefore they lack cooperation. And they are suspicious of everyone who comes into their space initially if it's for the first time. And so we should remember that they are not young adults that we expect them to understand, even structurally and everything. The structure of the eye and their behavior differ from adults. But there are some valuable assets that the book actually elicits. And that is that you should be patient with them. You should spend a bit of time to really ensure that they find you to be playful and friendly. And you need to be very patient. Okay, so you may not see a lot of patients in the clinic like the retina guys will do, or the cornea anterior segments will do, but you may spend even a longer time, but with few numbers comparatively. But you need to be flexible and you need to be creative and do a lot of things just to get your children in that case, cooperate with you. You can see some of the accommodative near targets that are there, but you can also use all other things. These are locally purchased, very cheap, pencils and pens, key holders. You can just get ones that are colorful and have other things on it that some may rattle, some may not. But of course, when you are using it to check vision, you do not want the ones that will rattle, but you want very colorful and bright colored toys to help you in their evaluation. So now you have a child who comes to you in the consulting room, and maybe they may be coming with a parent, and or a guardian, or sometimes maybe an older sibling who may come with a child. And it is important to always indicate who is giving you the information. You need to document that. So I think the essential things, and I'm not going to go through all that, we all know that it is important to find out from them why they are presenting, which is a presenting complaint. And that will determine the subsequent questions that you will ask. But irrespective of what they are presenting with, it is always important to ask when the symptoms started, because the age of onset will help you to know whether you are dealing with a congenital condition or an acquired condition. So for instance, if it is from birth, then you can assume that this is a congenital condition. So it is important. Of course, visual complaints, because the main aim is, of the eye is to see, and parents may complain about their children not seeing. And so you need to go a bit into that. Depending on what they present with, if let's say it is a deviation of the eye, then some of these questions will be asked, which I know will be dealt with in detail later, but you want to know about the nature, okay, of the deviation in the abnormal head postures and all the precipitating factors. You want to do that. Sometimes it may be that the eyes are shaking. You would want to find out about other developmental delays and other past medical history and medications that maybe the child may be on, which may give you an idea as to whether the child is being managed for maybe a neurological condition or a neurodevelopmental condition. Of course, if it is high sports, that will also elicit quite a number of these questions there. But it is important to be clear in your mind what they are presenting with, and make sure that you ask relevant questions and not like produce, some people just have a standard question that they ask for every condition. You may want to touch on everything, but make sure that each condition, you ask the appropriate question, so that if, for instance, it is tearing, you'd want to ask, because tearing immediately should bring to mind, are you dealing with something which is irritating the eye? Is it infectious or inflammatory? Is it, let's say, congenital glaucoma? So you want to be very clear and ask the relevant questions. Okay, and depending on the other presenting complaints as indicated here, you want to do that. remember that the history is like taking any medical history. But for ophthalmology, we always say that the past ocular history is also important to us, not just the past medical history. But for children, it is important that you go into the pregnancy history and then the perinatal history. It is important because you need to know what happened during pregnancy. And especially if you take a condition like cataract or a white spot, in our part, I don't know about the other countries, but in my country, rubella is a significant cause of congenital cataract. And therefore, you would want to find out whether there was any maternal rash, any febrile illness associated with some maternal rash, especially in the first trimester or the first or second trimester, and you want to go into that. So it is important that you ask about the pregnancy history, the prenatal and the perinatal. Of course, perinatal history is important because of sometimes the type of delivery, whether there's any birth asphyxia and prematurity. So you need to go into all that. Of course, early development is crucial. Some children may have normal pregnancy and delivery, but then early childhood, they start having some neurological, neurodevelopmental delays. And so it is important that once the child is in front of you, you don't just deal with the eyes, but you also go into the developmental history. And that once there is developmental milestone delay, it means that you will now have to really, if you are the first to be encountered, you want to now bring in your colleagues, the pediatricians, etc., to come on board. Of course, family history, and in this case, I mean, for children, we are not interested in the family history of diabetes, family history of hypertension. We are interested in other conditions, like whether there's a family history of strabismus, whether there's a family history of, let's say, refractive or short-sightedness, especially, or even retinoblastoma or any neurologic disorder. I know for some of us, I don't know about it, my other colleagues in the other country. In my country, we don't do any genetic testing, but you need to keep that in mind and ask whether there are any disorders, genetic disorders, any syndromes that are in the family. And we should remember that consanguinity is a significant or factor. In my country, for instance, we have some tribes that intermarry, and therefore you need to ask, and it should be routine. So you come to the examination. Of course, I have not exhausted the history because it depends on what they are presenting with and what you want to ask. So for the examination, I think from your answers, we want to still remind ourselves that, I mean, the children lack comprehension, they lack cooperation, but you still have to examine and you still have to get the maximum from them. And therefore, the assets we discussed earlier on, you want to make sure that you have all that, and also make sure that you are quite friendly and you're also in very nice, colorful clothes. So if it's at your clinic day, don't go with very dull clothes. You want to make sure that you have some nice, colorful dresses, or your white coat, you should have some other things, toys to use. So it is important that sometimes you can actually look at the child if you have a play area at the clinic. As they are playing and as they are there, you can actually start your assessment there as to how, I mean, they are visually interacting with the environment, whether they are bumping into things, etc. So it starts from the play area, and as they walk in, you also want to actually start your examination even before you start the history taking, because some of the children, you may see them actually with abnormal head postures, and you want to take note of all these before they come in there. And spend a bit of time to break the ice and let the interaction with the child, let them feel really big, that they are your special guests for the day. Sometimes you may be able to achieve or attain all your examination findings at the clinic or in the office, but sometimes you may not, and you may have to maybe sedate. And I think chloral hydrate is a very useful drug at the OPD that helps us. That, I mean, you don't need to take them to theater initially, but where it becomes very necessary, sometimes you may have to complete or confirm some of your findings under anesthesia. and you need to take note of all these. So these are important assessments, and I know we list them like this, but once the child comes, I mentioned that you may even start your visual assessment before you even start taking history by just observing how the child behaves. And it is also important that you don't just, rush and go to the eye, because sometimes you may have some features on the face that may suggest whether there's facial asymmetry. It's not enough to just say that, oh, there's facial asymmetry. Is there hypertrophy or atrophy of one side? So hemiatrophy or hemihypertrophy. For instance, if you have a capillary hemangioma, you may have a hemi hypertrophy of that side with port wine staining. So you want to take note of all these ones and some pigmentation as well. And of course, the torchlight in your hand, which especially for the pre-verbal child, that's a lot of things when we get to vision. Once you have that, you can also, in no particular order, you can also assess your ocular alignment immediately once the child is in front of you. Remember that the pupillary examination is important, and you may not have the attention for a very long time. So sometimes you are taking the history, you are also examining at the same time. And the things you need for anterior segment, you need some magnification. And it's not all the children who will allow you to use the slit lamp. If they are less than 6 months, of course, we know about the flying baby position, or if they are older children, they will allow. But for the younger ones, sometimes they will not. And therefore, sometimes you may have to resort to your 20D or 15D lenses, your plus lenses, magnifying lenses, with innate light source or your indirect ophthalmoscope to be able to access anterior segments. And when that is if in the office, but if they will cooperate for handheld slit lamp examination, that is also good, or the table mounted one. But you just have to examine and be sure of this. Intraocular pressure measurement, now it's become easy with the eye care, because that's one, you don't have to put in any drops and all that, but you need to indicate the type of equipment that you use for the examination. And I just want to say that the eye care sometimes can give higher results than the Goldman, and you need to know. And you have to also check it when the child is relaxed, any primary position, because with any movement of the eye, and you can try it on you, sometimes you can IOP can fluctuate from mid-teens to even mid-30s and even sometimes 40, just at the sitting. And if you don't take care, you may diagnose someone with glaucoma, ocular hypertension in a child, because the pressures are high. Always remember that before you dilate, sometimes if you are going to do the retinoscopy yourself, or if you have a pediatric optometrist or a pediatric oriented optometrist, sometimes they want to do a dynamic retinoscopy, especially when you are dealing with, let's say, strabismus or some accommodative problems. They want to do that and before they go on to do their cycloplegic refraction. But I just want to say that always ask, especially when you are taking your history about the early childhood development, about seizures, history of seizures, so that you avoid cyclopentally, because it can induce seizures. And sometimes it may not occur at the hospital or in the clinic, or happen later when they leave the hospital. Because if they have seizures, then you avoid that, and you can use maybe tropicamide and the others. Of course, your posterior segment, always remember that it is beyond the lens. So you want to check on your media clarity. And for children, sometimes, yes, the direct ophthalmoscope can help you. Your Brookness test you can do that. But the indirect ophthalmoscope can help you to also check on your media clarity, and then also to examine your eye. I find it very helpful that, at the same sitting, you can have maybe a number of lenses. Maybe you have a 20D that will help you with the posterior pole, 28D lens that can help you with it up to mid periphery. And if you have a 40D, of course you lose details, but it can help you grossly as to whether there's a mass or so beyond, up to maybe an appreciable part of the periphery. So a number of lenses can help you to do this. All right. So these are some of the examinations I do, and depending on the presenting complaint, other examinations will come in. Either maybe the ocular motility and all that will come in, visual field testing and all that will come in. But the basic assessment, you want to just make sure that every child gets a dilated fundus examination, either at the first visit or maximum the second visit. But it should be a practice. It shouldn't be that a child comes and never gets anything in this case.
Yeah, actually a question has come in on the chat box. What is the cut off of age for the Bruckner test?
You mean the minimum age that one can do that? I suppose that's what the person means. I think as when the child can actually fixate, is able to fixate, and we know that they can start fixating from 6 to 8 weeks. And so they can actually be examined. And now we are now training our frontline workers to be able to do that at the child welfare clinics or the postnatal clinics for them. So once the child can, in this case, fixate a bit, I think that can be done. Maybe my colleagues can, contribute to that.
So as ma'am said, definitely when the child fixates, plus in Bruckner's test, we can also do it if the child is having cataract or leukoporia or a vitreous hemorrhage, even in a younger child, younger than 6 to 8 weeks also, we can see. But Bruckner's test to know whether the child is strabismic or to know whether the child is having refractive error, yes, the child needs to fixate. So Bruckner's test is you use your direct ophthalmoscope, okay? And at a distance of about, say, 50 centimeter, you throw the light of your direct ophthalmoscope in both the eyes of the child and you see the reflex, okay? So it is useful to know whether the child is having strabismus. The strabismic or the deviated eye will have a brighter reflex, okay? It is also useful for undetected refractive error, the hypermetropia and myopia. You will have crescents, okay? Crescents meniscus when you're seeing through the ophthalmoscope. Plus, it is also, if the child is having cataract or say vitreous hemorrhage or say RD, you will have dull reflex over the pupillary area, okay? So Bruckner's test is very good screening test, especially when you're going for outreach programs. So as a screening test, just throw the light of direct ophthalmoscope onto both pupils and see the reflex. You will get to know whether the child should be evaluated further for strabismus or refractive error.
And now the frontline workers are using the arc light ophthalmoscope in some countries to do that. And it is simple, it is cheap, and as soon as they see an abnormal reflex, then they refer to the next level of care. So the visual development, just a brief one to say that we know that at birth is quite poor. Vision is quite poor because of the immaturity of parts of the eye. So in terms of visual development, there are some, I'm just touching on the milestones that can help us in the evaluation of vision of the children. And one of them is the pupil, which tends to be developed by 30 weeks of gestation. So for most children, by the time they are born, the pupillary reflexes would have been present. The only thing is that for children, they tend to sleep a lot, and therefore the meiosis tends to make it a little difficult for you to elicit. But that is one of the things that tends to occur. The occipital region of the human brain also has specific areas, as we know, the visual cortex, that interpret images that reach it. In terms of myelination, it goes on actually for weeks, even to years, almost 2 to 4 years after delivery, after life for complete myelination. But it tends to be present, or it tends to occur by 4 months of age. One tends to, in terms of the synaptic density of the visual cortex, it increases. One is born with a lot, but then it begins to decrease after birth, and about 40% of it would have been lost, okay? And by 10 years of age, they would have attained the adult density of of this. Of course, the macula tends to develop and also, tends to rapidly develop over the first 4 years of life, but it is present early parts of the first year, and it tends to develop as one goes on. Definitely the ganglion cells, as we said, tends to also generate, it tends to be developed within the first 8 to 15 weeks of gestation. And it reaches the maximum quantity, which is about up to about 2.5 million axons or ganglion cells postnatally by 18 weeks postnatally. But after about 30 weeks, it also begins to decrease. And this decrease goes on for some weeks for us to actually get the shape of the macula in terms of foam density, etc. For the refractive state, we already know that initially the child is a bit hyperopic and then tends to come back to to myopia, and then finally attains emmetropia or normalization by early teens. Some of the visual milestones that is worth keeping in mind, which we tend to use, especially in the pre-verbal child during visual assessment, is the fact that, as I mentioned, by 30 weeks of gestation, pupillary reaction is there. And at birth, the optokinetic nystagmus, which is a physiological nystagmus, is present at birth. It's just that the temporal to nasal tends to be earlier and better than the movement from nasal to temporal. And the first few days or weeks of life, the child is able, any child is able to blink to bright lights. So they blink to bright light, and we tend to make use of this, when we are assessing their vision, especially in the pre-verbal child. So by birth, one can use the pupillar light reflexes. One can use the blink to bright light, and even when they are sleeping and you bring a bright light, provided the child sees, they will blink. And of course, they're able to make and maintain eye contact or fix and follow by 6 to 8 weeks. And they become interested in bright, colorful objects by 3 months of age. And they can fix and follow visual responses, returning social smiles and all that from 4 to 5 months of age. And one can make use of these ones when you are examining them. So let's say that, so let me quickly just touch on it, that methods of visual assessment can be grouped into broadly, of course, the objective method, the subjective ones, and then the functional ones. The objective methods are the ones that you don't need any self-measure response from. The patient doesn't have to, response or, give you a response. You have to elicit, the examiner has to elicit these. And then the subjective methods, that one requires some self-measure responses like the matching test, the Snelling's, the log matches, where the individual has to give some responses for you to know that they can see. For functional one assesses the child functions every day in life. Let me quickly say that, so you can group the tests for assessing children's vision. There are some tests for neonates, for infants, and each subsequent age can make use of the previous ages methods. So for instance, infants, for the infant group, you can still use the methods in the neonatal group in addition to what is for that particular group. So for neonates, we've said that the pupillar responses, the optokinetic nystagmus is present at birth, the visually evoked potential is also present then. And so you can also use that, okay, to assess their vision. And they are also able to blink to bright light. And by 1 month of age, they are able to actually grossly appreciate the human face. And that's a potent stimulus for them. So you can find out whether they focus on the mother's face when they are breastfeeding. So this is a visually evoked, which is an electrical activity. It's measured. This is the optokinetic nystagmus, the drum that in this case elicits the movement in terms of, the nystagmus, where the child, as it is turning, the eye repositions itself maybe from black to white stripes. And so that nystagmus, which is a physiological one, helping it to reposition its and macula of the fovea or the eye on the next object of interest is there, and one can do that. Then the infants, for the infant group, it is more the physician methods, okay? And then also the central, which can be recorded as a CSM or the central study maintained. First two are actually monocular tests. So you try to find out if each eye actually focuses or has a fovea central fixation, making use of the fovea, and whether it's steady, meaning that there's no nystagmus or any shaking of the eye. Maintained is when you take off that cover, when that eye which is covered, when you take it off, whether it was maintained, it will regain fixation or it stays deviated, in which case you can assess. If it is not maintained or under binocular conditions, then you can see that it is not maintained. So sometimes they will put, whichever one is not present, you put an N. So not central, not steady, not maintained. Or sometimes they will use U, unsteady, uncentral, unsteady, not maintained. But N in front of the particular factor, it says it's that it is not present. Of course, the first choice preferential looking test, which can be used from 3 months onwards, actually the basis is that if you present anything to a child, we have the resolution ones and the recognition optotypes. And if you present anything, one side plain and the other side with a pattern, any child who sees, a pre-verbal child, if only the child sees, will turn and look at the part that has the pattern. So these tests have been done such that one side is plain and the other, it has a pattern, either a grating stripes or a vanishing optotype where there are, yes. So you can use that. So you force the child to actually prefer to look at a particular side. So these ones are some of the tests that can be used. And these are some of the preferential looking tests. And the fixation ones are, also used to determine which eye the child prefers to use. If it's a toddler, in this case, we are looking at between 1 and 2 or 1 and 3 years. You can also use the hundreds and thousands, which is the cake decoration, is very cheap. And you have a lot in a container, you can use that. And of course, the other ones, the Leah symbols and the Cardiff cards can also be used for this age group. The preschoolers between 3 to 5 years of age, you can then use the matching test, and it becomes like fun for them. If you make it interesting, they will do it if only they see when you are testing each eye at a time. And these are the charts that can be used. Of course, when they are 5 years or more, they can then use the charts that the adults use, whether the Snellings or the logma. So these are some of the optotypes, the Leah symbols, and then there's the K pictures where it's a patching test. But you see that in the HOTV, if you suspect that there's amblyopia, then you have to use this particular one with the crowded bars around it instead of the single optotypes, because in that case, it will help you to pick the children who have amblyopia. If it comes as single, they will be able to read everything. But if they have these bars, crowded bars around it, it's one of the deficits that occurs when there's amblyopia, and therefore the vision will be lower than anticipated. So this is also a matching test for the preschoolers. Snelling's charts and the logma charts, these are examples, and I'm sure we have them there. This tells us, the age at which we should expect some normal visual acuity depending on the type of test that we are using, grossly or roughly. So, 2030, visually evoked potential, they will attain that by age 1. It means that you should have an idea the age that they can attain this, so that if you have a 3-month-old baby and you are getting, let's say, you are using, let's say, preferential looking tests, and maybe you are getting, you don't get 20/20, you don't get worried, okay, that there's something really wrong, because may not that age, they may not be a 3-month-old baby may not be able to attain that. So that's for the visual assessment. Can you tell us or type in the chat some of the signs that will signal that a child has poor vision. Okay.
So
Mhm.
staring, fixation preference, nystagmus, wandering gaze,
Okay. All
then
right. Okay.
nystagmus continues, then wandering eye movement, avoid
I can see that
occlusion.
my lecture on that is certain because the answers are just coming like that, you know.
Way to
So
go.
well done. So I think you've mentioned all of them. I just want to say that sometimes the children who come in rubbing the eyes, sometimes they are misdiagnosed as having allergic eye disease, and sometimes they prescribe drops and all that for them because they are rubbing the eye. But if a child comes in who is not interested in the environment or in familiar faces, and the person is rubbing the eye or poking the eye, then you should suspect that this may be a sign of poor vision, okay, in this child. And it's likely to be an oculodigital reflex. And in this case, you know, sometimes you can stimulate the retina either by light, either by mechanically, okay. So sometimes they also try to do that, and the sparks gratifies them. So always remember that if the child has other signs of poor vision and they are poking the eye, or then you should consider that it may be this. And sometimes it's likely to be maybe an ocular medium opacification if this particular thing exists, and you want to take note of that.
Question is head tilt also a cause? Because that was also mentioned in the chat box.
Head tilt is an abnormal head posture, and as we know, it is one of the adaptations, okay? And sometimes it will let us know that that child was actually visually developed or alert, and therefore trying to avoid diplopia. And so it can tell us that there is probably diplopia, or the person has an acquired cause for whatever is happening to the person. All right, so I think we are familiar with this already. I'm not going to go into this, but I just want to just indicate that I find it difficult remembering, okay, the muscle direction of pull and all that. And this chart, for instance, helps me to know and for me to deduce which eye movements I should expect. So for instance, if we look at this, we can see that, I mean, as we know already, this is, let's say, the visual axis, okay, or the visual axis or the anatomical one, but the eye is positioned such that the muscles that come in, the four recti, they run such that they go and insert anterior to the equator. And then the two obliques insert posterior to the equator. We can see the insertions of the superior oblique and the inferior oblique here, but the recti, the four recti, they all insert anterior to the equator, and that helps us, I mean, it helps the eye or helps us to deduce the kind of movement. Secondly, in the primary position, we can see that the vertical recti, in this case, the superior rectus and the inferior rectus, we know already that they make 23 degrees, an angle of 23 degrees from the visual axis. So when the eye is in primary position, this is there. Usually, so it means that, and then for the obliques, this, of course, the mechanical or the physiological insert origin for the superior oblique will be the trochlea, as we know. But the visual axis and that particular insertion, or where it is coming from, it forms the 51 degrees. So in the primary position, it is at an angle. Now, if we look at this, where it is now, if this muscle, and this is I think this is the superior rectus. Can you see the laser points?
Yes.
Okay, so this is the superior rectus. Okay, so it means that in the primary position, this is the superior rectus. So in the primary position, if it contracts, if this muscle contracts, is going to actually, and it is inserting anteriorly. So it's actually going to pull the eye up where the back will be going, so it pulls it up. And so there will be some elevation there. And because of this 23 degrees that is there in the primary position, it means that it's going to actually intort. And when we talk about intorsion, let's always remember that the reference is the superior pole, okay, the vertical pole, the superior part, where it turns. So if the superior part of the plane or the superior pole of the vertical plane, if it turns or twists nasally, then we say that it's intorting. And if it turns temporally, then we say that it is extorting. It's not having reference to the inferior pole. It is always in reference to the superior pole. So it means that if, for instance, this one pulls on it, you're going to have a situation where the upper part of the vertical pole is actually going to turn this way inward. Please, can you appreciate that?
Yes,
Because,
yes, with the pointer.
yes, so I'm saying that this is the superior rectus. So yes, and this is the primary position. We are saying that if it contracts in this position, number one, because it is inserting anteriorly, it's going to actually pull the eye up. So there'll be some elevation. There will be some other secondary in the primary, there will be some other movements as well, because of how it is inserting with respect to the visual axis, its relation with respect to the visual axis. And I'm saying that because if, for instance, it was to align itself with the visual axis, then it would just be elevation, a vertical movement. But because there's an angle in the primary position, if it elevates, it's also going to twist the superior part of the vertical pole inward or nasally. And therefore, it will be intorting. And I've said that intorsion is when the superior pole actually turns nasally. And if it turns temporarily, it will be extorsion. You get it? It's not the inferior. So in this case, if you take, let's say, the inferior rectus, which is the opposite of the superior rectus, okay, that one is also inserting anteriorly, anterior to the equator, okay? And so when it pulls, it's going to actually pull the globe down. And this is the bottom one. It will pull it down. In this case, there will be depression. But as it pulls it, it will be turning the superior parts in the opposite direction. So the globe will be turning in the opposite direction. The superior pole will be turning in the opposite direction. And therefore, it is extorsion and not intorsion. Sometimes there's a tendency for one to think that, it is the inferior pole that's going to determine whether the eye is going to turn in because of the direction of it. But it is always with respect to the superior pole, which is going to determine whether it will be intorting or extorting. So, I just wanted to just say that. So in this case, if, for instance, one wants to see the pure vertical action of the superior rectus, for instance, then the eye has to abduct. In this case, if it abducts about 23 degrees, the eyeball abducts 23 degrees. In this case, the visual axis will be, this axis here will be aligning itself with the muscle, the axis of the muscle. And therefore, when it contracts, it will just elevate without the intorsion and all that. But if it's in the primary position and it does that, then one will get all these other movements in addition because of how it is angulated or how it's. I know it's a little difficult to appreciate, but I just hope that I've made a bit of sense with what I'm trying to say. That if the muscle, the axis of the muscle is in line with the visual axis, of course, the pull will be 90 degrees to it and it will be just in a particular direction. If it is at an angle, let's say 23 degrees or 51 degrees, then that component will come in. Either it will be twisting it in that direction, or unless there's a movement to align the visual axis with the axis of the muscle for us to get a pure. That is why if, let's say, one wants to see the pure action of the superior rectus, then one needs to, the eye has to move into abduction, in which case about 23 degrees, in which case the axis of the muscle will align with the visual axis, and there will be a pure elevation in this case, function to elicit. For intorsion, extorsion, always the reference is to the posterior pole. So with this particular one, these are the obliques. And with the obliques, they are inserting posterior to the equator. Okay. Once they insert, they are inserting to the equator, it means if they pull the eye, the posterior part of the eye will be, for instance, the superior oblique will be pulling it towards its functional insertion, which is the trochlea. So if you look at this muscle here, and let's say it contracts, it's going to pull on this part of the globe and pull it up. And that is why it will be depressing the globe, because you are moving the posterior part of the globe up. So it will be turning the eye down. In this case, I'm talking about in the primary position. But it is at such an angle such that the visual axis is actually at a certain angle, 51 degrees, okay, from the angle of the muscle, which is this one, the functional part that we are seeing there. So in this case, the posterior pole again, once it moves this one up, it will actually intort. It will move or push the posterior pole towards the nasal side. And therefore, that's an intorsion, because the posterior pole is going that way. But the eye, once it moves in that direction and the posterior part is pulled up, the eye turns out. So it's going to be, it's difficult, but it's going to actually look out. So it's going to look down. It's going to, twist it inward, the posterior pole. And that's going to let the eye actually turn temporarily or outwardly. And so it will be abducting. So the obliques, they both abduct because their movement will let the eye look outwards. But then the depression is one of their, is what they would do. They both would be depressing. And in this case, the intorsion is for the superior because the posterior pole is going inwardly. But the inferior oblique is opposite to the superior. So once it pulls it, it will be turning the eye, it will be twisting the posterior pole out. So I think if you take time and you look at these mechanisms, it's easy to follow if you are taking it one by one. But if you are trying to remember, oh, will it intort or will it then, especially when you are growing old, like some of us, then it becomes difficult to remember whether it is intorsion or abduction, but you just have to at least have a way of deducing, and in that case you will not forget. And that's what I want to say about that one.
From my residency days, I remember the mnemonic SINRAD, and I posted it on the group. SIN, S-I-N. So superiors, I know the pediatric ophthalmologists are going to say, no, we have to teach them the reasoning behind it, and you please teach them the reasoning behind it. But I'll tell you my shortcut, which is that superiors intort, right? And so what does that mean? Superior rectus and superior oblique intort, right? And then recti adduct, SINRAD, ADD. So it's adducts. So recti adducts, which, what does that mean? The opposite, if it's not a rectus muscle, it is a oblique muscle. If I remember SINRAD, then I remember all the muscles. I remember if superior is intort, that's superior rectus and superior oblique. And that means that the opposite, which is inferior, right, would be extorting. And then recti muscle adduct, and what's the opposite of recti muscle? Or the only other option is oblique. And so if it's not a recti muscle, they abduct.
Always remember that if it is inserting anterior to the equator, it's likely to pull along the vertical bit of the front part up or down. And if it is inserting posteriorly. Of course, if it is superior, it will pull it down because the back of the eye will be pulled out. I think I don't have to go through the ductions and just for them to know that once it is duction, it's a monocular rotations or movements. And it is when it is it is a movement in one eye. And we should always remember that in each eye, you have the agonist and you have the synergist, you have antagonist, and then we should remember the Sherrington's law of the reciprocal innervation, which, so this is actually easy to remember. So I'm not going to spend too much time on this one. And let's remember that for the binocular eye movements, so the ductions are always monocular movements. The binocular eye movements are the two versions and vergences. Versions move together in the same direction. Vergences move in the opposite direction. Vergence, that's what I remember. So convergence or divergence, divergence, and then the versions, of course, will move in the same direction. And let's remember also that for yoke muscles, they will be in one in each eye, but they move the eye, okay, into the same field of gaze. Okay, so one muscle in the other eye and the other in the other eye, and they are moving the eye into the same field of gaze. And let's remember that the Heron's law, that one goes for binocular eye movement. The Sherrington was for the ductions, okay? And this one goes for the binocular eye movement. But let's quickly let's remember that for the binocular movements or eye movements, they are actually under central control. So we have supranuclear control systems, okay, for the eye movements. Some in the visual cortex and then coming down. I think the neuro-ophthalmology section will tackle that, okay, in detail. But they are actually under control, central control, and the system actually comes as I have put here. So there are basically two systems, two systems or movement that facilitates the binocular movements in the eye. And these ones, they come as gaze shifts or gaze stabilization. And whichever system or level that they are operating, they are working together to keep the eye, okay, if they shift, they should move together and the gaze should be stable. It shouldn't be shaking. And the systems work together to ensure this. And they are under controls from higher centers to do that. So different regions in the brain, that's the cortex and brainstem, ensure that these controls, okay. And I think the neuro-ophthalmology book will touch on this in detail. Briefly, let me touch on the sensory physiology, because that will be the basis in this case, explaining amblyopia, etc. So quickly, of course, we know that if we are looking at anything, the imaginary line that connects the objects of interest outwardly to the fovea, that imaginary line is what we are referring to as the visual axis. So it is an imaginary line that connects the fixation point out there to the fovea. Now, we're saying that there are some terms that we come across. So the retinal correspondence, and we're saying that if we are looking at any object out there, there are some points on the retina that if this object, the image of that object falls on these points, and you are able to see that object, let's say as one or perceive it as one, then we will say that that particular, those 2 points on the retina are corresponding, okay? So it's when, a viewed target stimulates a paired retina areas in an individual's 2 eyes. Usually the fovea does that, but you can also have some other extra fovea sites, which are not too far from the fovea, which can also act as a retina correspondence, or they can correspond with each other. And in this case, allow an image, to be seen as one by the two eyes. And this panum and the horopter, of course, the horopter is supposed to, the panum goes beyond the area that the retinal correspondence is okay. So there are some, the normal human visual system is able to still accommodate or combine the images from sites which are may not necessarily be corresponding. Okay, I've already said that the two fovea correspond, and then sometimes immediately outside the fovea, if they are close to each other, they can also correspond. But sometimes you can have maybe, two sides which are not really within what we've talked about, but the human brain is still able to fuse the two images together. And it is said that this area within which the brain is still able to fuse the two images together, okay, which not necessarily stimulating corresponding sites will fall within this area that we call the panum area. So it is important for us to remember that, but the horopter necessarily have to be, points that, stimulate corresponding sites. The panum does not necessarily have to be corresponding sites. They can still be disparate points, but the brain is still able to do that because the human brain is able to do that. So stimulation of non-corresponding, but if they are very wide apart outside this panum area, which the brain is able to accommodate, even though they are disparate, then the brain will not be able to fuse the images together. And therefore, the particular object will be sensed or appreciated as two objects, even though it is one object. But because it is stimulating disparate areas or different points or loci, which are not corresponding, the brain is not able to fuse that, and therefore it projects the images as it receives that. So if it is a brain that has already developed functionally, then and structurally, then that person will begin to see the thing as two, okay, called diplopia. But if it's a child who is younger, sometimes the brain is so plastic that sometimes they're able to suppress the one that is really off the fovea, the extra fovea side. Children who are younger, then they're able to suppress that. So there are two ways that the brain is able to, let's say, suppress these abnormal stimulations if it is outside the corresponding sites. And one of them is that it will either suppress it or it will project it to the individual. The effect of this is that sometimes if, let's say, the disparate points are stimulated and one eye is constantly presenting, let's say, abnormal signals to the brain, within that age group, which is the first 7 to 8 years of life that the visual cortex is still developing and other parts of the brain towards the eye is still developing, then there can be some structural changes that can occur. So let me finish with this particular one, and then maybe I will just conclude for the amblyopia bit of it. So in this particular case, when there is, let's say, blurred vision, so if it's, let's say, an extra fovea site or disparate site, a site that is not corresponding with the other is receiving the images, then that one, whatever goes to the brain, it leads to some structural changes with time. It's not just functional. So the changes occur at the lateral geniculate body, where there's narrowing of some of the nuclei, and then also the striate cortex, the visual cortex, to suffer, because it then tends to also show significant loss of the fibers. And that sometimes, that sort of forms the basis of amblyopia, where there is loss of, is not able to, there's loss of this binocularity because the brain has lost the fibers, some of the fibers, and is not able to regain that if it is if it goes beyond a certain age, then it's not able to regain that, as is depicted by this picture. And that then will form the basis for amblyopia. So I have said that if the functional consequences of this misalignment, or when there's non-retinal correspondence and one image is not very clear, or the cortex is not receiving as it should be within that age group, there can be amblyopia, okay, which tends to also be both functional and sometimes structural changes in the brain at the brain level. And there can be confusion. The confusion is when, let's say, one object is stimulating the fovea in one eye and another object is stimulating an extra fovea one, and is presented to the individual, and that is confusion. And that is more for temporal sight. But the macula usually does not allow that, but there can be rivalry. So the same object will be sometimes alternating, and we call that one the retinal rivalry. But these are some of the adaptations that can occur. So, I mean, diplopia or anomalous states, where the anomalous ones can be confusion or retinal rivalry. Abnormal head postures become some of the motor adaptations for some of the motor problems that, motility problems that tend to occur, like strabismus. I think I'll pause here, and if there are questions later, then maybe, but so other tests which the book has actually talked about will be some that assess sensory thing, and then some that assess the motor function. But it is important that forms the basis for
You,
the
Professor.
assessment.
Thank
So
you.
if there's any questions, and then maybe I can come back and then answer some of the questions. Thank
You're
you so
the
much.
best, Professor. Thank you very, very much. That was wonderful. And I'm telling you, it's jam-packed. But we also love our residents to pre-read, right? And so all of you are already experts on the topic, and this is the second time you're reviewing it, and I hope that it becomes clearer and clearer for you. One thing we definitely want to encourage, as questions come up regarding the first 6 chapters or anything for that matter, please do post it on the group so that Professor and others, I saw Dr. Rohita has also joined in from Tilganga. Welcome, Dr. Leena. She's cornea. She's also with us. Welcome, professors. So please do post your questions on the chat box so that this great conversation from chapters 1 through 6 continues on the chat box with Professor Vera Essuman, as well as all the other faculty that are here for you. I'm going to hand it over to Dr. Sayali Mahajan. Dr. Sayali and I know each other quite well. She is assistant professor at KEM Hospital, Mumbai, India, where we were there together. She is a postgraduate from the very famous Aravind Eye Hospital, and she did her pediatric ophthalmology fellowship from Joshi Eye Hospital in India, and is a very, very, very smart pediatric ophthalmologist. She looks young, but she is someone who can relate the information and make it easy. We are just so honored to have you, Dr. Sayali, to be with us, to teach us the strabismus.
So thank you, Professor. A wonderful foundation you have laid. So I'll take over from here for the clinical point of view. So I'll start with ESO deviations. So we know that ESO deviation is inward deviation of the eye, and so it could be latent or it could be manifest deviations. Risk factors could be anisometropia, hyperopia. You have neurodevelopmental impairment, prematurity, low birth weight, craniofacial or chromosomal abnormalities. So I would like to ask, can anyone tell me what is primary deviation and what is secondary deviation? Primary deviation is when the normal eye is fixating. Okay, so here you can see this, the right eye is in ESO, the left eye is seeing straight, so it is primary deviation. Why? In this, the left eye is covered. So the right eye has to take a fixation. So this is the secondary deviation. Okay. So if there is a deviation, right? Right eye is deviated. Okay. The left eye is straight. Right eye is in EZO. So it is deviated. So in simple terms, primary deviation is when the normal eye is fixating. Secondary deviation is when the left eye, which was normal, is covered. So now the deviated eye is taking a fixation. So secondary deviation means when the deviated eye is taking up fixation, it is secondary deviation. When the normal eye is fixating, it is primary deviation. Why do we need concomitant and what is inconcomitant? Okay, so basically concomitant deviations are the ones when the deviation is equal, when it is normal eye is fixating or the deviated eye is fixating, comes to you. Okay, and inconcomitant deviation means when the secondary deviation, that means when the seemingly deviated eye is fixating, that is more than the primary deviation. So what comes as concomitant is there is no limitation of ocular movements, wherein in concomitant there is limitation of ocular movements. Since there is no limitation of ocular movements, the patient may or may not have diplopia, and that is why they may not have abnormal head posture. Whereas in inconcomitant deviation, since there is a limitation of ocular movements, the patient will have diplopia and will try to have binocular single vision by having a abnormal head posture. So what are the examples? The examples are accommodative esotropias or intermittent exotropias. So in this, the deviation would be same in all cases. The primary and secondary deviation would be the same. Whereas in inconcomitant deviation, we have the nerve palsies, that is third nerve, fourth nerve, sixth nerve palsies. We have post-trauma restrictive strabismus and thyroid myopathy. So these are restrictive conditions wherein we will have limitation of ocular movements, and when the deviated eye is fixating, the deviation would be more than when the primary eye is when the normal eye is fixating. What is pseudo-esotropia? So as you see in this picture, it looks like the baby is having esotropia, but is it really? If you see, the baby is having epicanthal folds. The nasal bridge is a little broad. So in such cases, you will have pseudo-esotropia. How will you differentiate it? Actually is just cover one eye and see the movement of the other eye. If there is no movement, then these eyes are in ortho position. Okay, so how will you differentiate clinically a pseudo-esotropia from an esotropia? Actual esotropia is do cover test. You will see that the eyes won't move at all. That means they are in ortho. So like flat and broad nasal bridge, prominent epicanthal folds, narrow interpupillary distance, and negative angle kappa. One more thing we need to know in ESO deviation is what is accommodation. So can anyone just tell what is accommodation? Okay, so accommodation means whenever a person, a child or anyone needs to see near objects, it will increase the size of the lens. The lens will become more convex so that the image forms on the retina. That is accommodation. And what does accompany accommodation is, you will have pupillary constriction and you will have convergence. Very good. I'm getting very good answers on the chat box. So correct, that is accommodation. Very good. These are the associated conditions. Very good. Very good. So if I'm seeing the chat box, I think someone is having a question. How do you differentiate pseudo-esotropia from paralytic esotropia? I think I've answered that. You need to do cover test. If the cover test is showing First of all, paralytic esotropia, if it is the paralysis is complete palsy, you will have the Hirschberg. When you're doing Hirschberg test, the corneal reflex won't be centered. And secondly, if it is paresis, that is the eye can move a bit, at that time you will have a movement on cover test. Okay. The next question which I am seeing is, why is secondary deviation larger than primary? Okay. So when professor was explaining the Herring's law, what does Herring's law state? In conjugate movements, whenever the supply goes to one muscle, equal supply will go to its yoke. Okay. So secondary deviation means whenever a palsy or a paretic muscle will get supply, that time its yoke, which is normal, will get equal supply. So the paretic muscle to perform its action will require more supply. So more supply will be given to its normal yoke. That's why when paretic eye is taking up fixation, the deviation will be more than primary in restrictive and palsy. Okay, I hope I answered that question. And yeah, someone has already answered it. Very good. Thank you. What are the components of hypermetropia? Can someone tell me? Total hypermetropia has latent hypermetropic component and manifest hypermetropic component. Manifest has facultative and absolute. So what is latent hypermetropia? It is the inherent ciliary body tone. What is facultative is the accommodation which you can do voluntarily. Okay. And what is absolute hypermetropia? In spite of using your own accommodation, still the remaining manifest hypermetropia is there. That is absolute. Okay. You need this basics for further discussion. So latent would be inherent ciliary tone, facultative would be the voluntary accommodation, and absolute would be the remaining hypermetropia. So accommodative esotropias are, so as I said before, and also I'm getting the answers in the chat, that accommodation comes with convergence. So if the child is accommodating more, there will be convergence and inward deviation of the eye. So what we have, components of accommodative esotropia. One is refractive. So the child is having high hypermetropia, and that is why he is accommodating more, and that is why he's having esotropia. The other is non-refractive accommodative. So in that, the child may or may not have hypermetropia or have very little hypermetropia, but there is something called as high AC by A ratio. The third one is partially accommodative. So partially means there is refractive component and non-refractive component. And the fourth one is hypoaccommodative esotropia. So there is the accommodative component, the accommodation of amplitude of accommodation is low in that person. So to see near object, he will try to use whatever voluntary accommodation he can. And in that trying, he will be having esotropia. I'll explain each one. So refractive accommodative esotropia, as I said, uncorrected hypermetropia, average of 4 diopters and more, develops at around 2 to 3 years of age. And when do you see that, when do you say that it is refractive accommodative esotropia, is when there is less than 8 prism diopters of deviation after wearing their full hypermetropic correction for at least a period of 4 weeks. So what happens if a child comes to you after 4 weeks and still is having esotropia? Then you have to do the cyclopentolate, or atropine again. So first time he comes to you, you will see a child with esotropia, use cyclopentolate eye drops, or you give atropine eye ointment twice a day for 3 days. Prescribe the glasses if they are more than 1.5. Call the child after 4 to 6 weeks. See how much has the esotropia decreased. If it still hasn't decreased, again perform cyclodilatation again. Again repeat retinoscopy. Again see how much is it. If it is more, prescribe the new spectacles. Call the child after 4 to 6 weeks again. Even after that, if
This
you
is
see
such a- I just
that
want to
it is still,
pause, because that was such an
yeah, sure.
important teaching point. That's
Yes,
such an
yes.
important teaching point, and I hope everyone understood it. Okay, if you don't, post on the chat box or ask the question, because it's such an important point. Dr. Sayali is taking you step by step what you're supposed to do.
Yes, I'll explain again. So a child comes to you with esotropia. What you do is give him cyclopentolate eye drops, or you can give atropine ointment twice a day for 3 days. Call him to your clinic again. Do the retinoscopy. If it is more than 1.5 diopters, prescribe glasses. Call him after 4 to 6 weeks, say 1.5 months. If still esotropia persists, don't jump to conclusions that it may not be refractive or it is partially accommodative. No, you repeat the cyclorefraction again with cyclopentolate or atropine. Repeat again. If again you get hypermetropic, it is more, then give the new prescribed spectacles. Call the child again after 6 to 8 weeks. Even after that, it is still persisting. The esotropia is more than 8 to 10 prism diopters. Then you can say that it is partially accommodative esotropia or high AC by A ratio, when only the near esotropia is residual remaining. Okay, I hope I have cleared it. So next we go to the non-refractive accommodative esotropia, that is high AC by A ratio. Now let us just see what is accommodative convergence. As we spoke before, with accommodation, convergence comes in. Okay, and so AC by A means per diopter of accommodation, how much is the accommodative convergence in prism diopters. Okay, so let's just say that you give the patient a target for a distance of 6 meters. Okay, you do a prism cover test and you note down your findings. Okay, now you do is give a near target at 33 centimeter. So for near, the accommodation would be 100 by 33, that is 3 diopters of accommodation. Check again for near how much of esotropia is persisting by prism cover test. Okay, so let's say that for distance, the esotropia was around 30, and for near, the esotropia became 60. So 60 minus 30 is 30. So the patient is using 30 prism diopters. The patient is causing 30 prism diopters of accommodative convergence for 3 diopters of accommodation. So per diopter of accommodation, the accommodative convergence is 3. Am I clear? Did you get what I was saying?
Okay, please let us pause here and make sure that everyone understands, because this is important, this is foundational, and it's worth going through it again if it's not clear in anyone's mind.
Yes, I just tell once again. So you do take the prism cover test, measure the deviation for distance, measure the deviation for near, subtract the deviation, okay, and divide it by 3, because 3 is the amount of amplitude of accommodation you would be using for near deviation. If it is around 3 to 5, the AC by A ratio is normal. If it is more than that, it is high AC by A ratio. Okay. So whatever target you're giving, the target could be anything. It could be a Snellen chart, or for a child, it could be a toy at a distance or a video at a distance. And for near, it could be smaller toys or a target which has pictures in it. Okay. So that the child will have interest and look into the fixating target. So there are methods. There is heterophoria method, there is gradient method, clinical distance method, and fixation disparity. So basically we do it by the gradient method. You subtract the deviation and then you divide it by 3. Okay. So if there is high AC by A ratio, what will you do? So that means for distance, the patient is having some amount of esotropia. For near, it is having a higher amount of esotropia. So at such times, you give them a bifocal glasses, executive bifocal glasses, wherein the upper part would be the refraction, the cyclorefraction for the distance, and the lower part would be cyclorefraction for the distance, plus you will relax the child's accommodation by adding +2 to +2.5 diopters more. Okay. And this executive glasses, the center line should pass through the center of the pupil. That's how the child will see the distance and near clearly, and you will clear up the esotropia. So bifocal glasses, executive types. The other thing you can do is myotics. They facilitate accommodation and hence will accommodative convergence. Or you can do is bilateral MR recession or Fardens. Okay, if at all, bilateral Fardens, and you can do slanted recessions. Okay, for near you will recess more. For bifocals, how will you
Sorry, Dr. Sayali, question please.
Yes.
What is Fardens?
Yeah, so Fardens means you will have to posteriorly fixate the MR muscle to the sclera, and its action will only decrease in the gaze in which the agonist the MR is acting. Okay, so when you do Fardens for MR, it will act as recession, but only in adduction, not in primary gaze or in lateral gazes. So why do we do that? Since the esotropia is more for near, the convergence is more for near, so it will act only in near gazes when your eye is converging or both eyes are adducting. It won't have that much effect in primary gaze or straight gaze or in lateral gazes. Okay, so that is Fardens. So when you're giving bifocal, how will you wean? You have to wean slowly in steps of 0.5 to 1 diopters, wean by the age of 10 to 12 years. If you can't wean, then you will have to go for surgery. The next is partially accommodative esotropia. So even after doing cyclorefraction twice, you are still having residual esotropia more than 10 to 15 prism diopters, then it is partially accommodative. So there is a non-accommodative component to it. So what are the non-accommodative component? So the child might have had esotropia since his infancy, infantile esotropia. So infantile esotropia is non-accommodative, and the child will also have super added accommodative part. So the accommodative part was his hypermetropia. And since the child has infantile esotropia since the first month or first 6 months of his life, that is why he is having partially accommodative esotropia when he has presented to you. Or there is decompensated accommodative esotropia with superadded non-accommodative component. So what is a non-accommodative component here? There is increased convergence tone or there is hypertrophy of MR. Let's move on to infantile esotropia. So if you see this child, a very nice chubby child, there is esotropia. Also, if you compare the lower limbus, this limbus is slightly at a higher level. Can you tell me what is this? Okay, fine. So this is IO overaction. Okay. So infantile esotropia begins on the first 6 months of life, large in magnitude, more than 30 prism diopters. Associated component is latent nystagmus, DVD, and IOA. DVD is dissociated vertical deviation. IO is inferior oblique overaction. So mostly if you see dissociated vertical deviations and inferior oblique overaction, you may conclude that there is disturbance in the binocular vision of the child in the first 6 months of life. It could be infantile esotropia or exotropia, or it could be that the child has monocular cataract or the child had monocular ptosis. These are the components which can happen. So also nasotemporal asymmetries of OKN. If you have binocular disturbances before the critical period of the child developing binocular vision, you will have these things accompanied by it. So what is nasotemporal asymmetry? Is if you rotate optokinetic drum from temporal to nasal side, it will be smooth following rapid and accurate refixation. Okay, but if you rotate it from nasal to temporal side, there'll be jerky, inaccurate movement with halting refixation. So next time you see a child with DVD, inferior oblique overaction, or nasotemporal asymmetry, you can say that the child was having some binocular disturbances, binocular fixation disturbances before the critical period of binocular fixation was achieved. The next we have is cross fixation, ductions, and vergence. So cross fixation means child with infantile esotropia will fixate the right field of his vision with left eye and left field of his vision with right eye. After it crosses a point wherein this eye will stop and the other eye will take over. So this gives an impression that there is pseudo divergence deficiency. How will you know that there is not actually a pseudo divergence deficiency? Just see this video. Just see at the last what I do. So if you saw in the end, this eye was looking as if the abduction is deficit. I do a doll's head maneuver and I got a full abduction. The other way you can check is just patch the other eye and show a video or a toy and see if the abduction is full, because those will be the differentials you will have to rule out in a child with infantile esotropia. So as ma'am explained, how to check vision in this child is central, steady, and maintained. This will tell you whether the child has developed amblyopia in either eye, whether the ocular movements are full, and also if the child has started developing eccentric fixation. So what are the differentials? Like I said before, pseudoisotropia, congenital sixth nerve palsy, you will do a Dolcet maneuver or just patch the other eye and see if the abduction is full. Duane's retraction syndrome, again, if you patch the other eye, you will see the abduction deficiencies there or not. Nystagmus blockage syndrome. So what is nystagmus blockage syndrome is? The child develops has nystagmus. It blocks the nystagmus by converging. Okay, so this could be another DD. In infantile esotropia, there will be latent nystagmus. That means a nystagmus will come when you close one eye. Nystagmus blockage syndrome, the child will block nystagmus by adducting the eye. Okay. Mobius syndrome would be 6th and 7th nerve palsy. You will have lagophthalmos along with abduction deficit. You have Seansia syndrome. Again, there'll be abduction deficit. There'll be end gaze nystagmus plus there'll be abduction deficit. Early onset accommodative VT, you will get through it because I've already told you, you see a child with esotropia, you do cyclorefraction in everyone, okay? And congenital fibrosis syndrome. So this is a restrictive strabismus, comes with congenital cranial disinnervation syndrome. So always check anterior segment and fundus in all patients, refraction under cycloplegia, and measurement of deviation will be by Krivsky because the child may not be cooperative for your prism cover test. Why should we treat? Because according to congenital esotropia observation study, they found out that infantile esotropia persists in 98% of infants. You have large magnitude, more than 40 prism diopters. The esotropia is constant and onset after 10 weeks of age and refractive error in less than 3 diopters. If we don't treat them early, they will have a letter subnormal stereopsis and binocular vision. Okay, so when should you operate? You operate them before 2 years to optimize binocular cooperation, as early as 4 months, and of course, if possible, treat amblyopia before. But studies say that even if amblyopia is left untreated, there'll be successful post-operative alignment if you do the surgery early. How to treat? For smaller deviations, you can go for botulinum toxin. This gives you time to actually see the child in around 2 to 3 months down the line, so that you know whatever measurements you have taken are correct and they are reproducible. The treatment would be bilateral MR recessions, and for more than 60 prism diapers, you can go for 3 muscle surgery. So this is another entity called acquired non-accommodative esotropia. So this esotropia is non-accommodative. So it rules out the other refractive or high AC by A ratio parts, and it is acquired. So suppose a 20 years old person comes to you, says, I'm having diplopia since a month. My eye has turned inwards. What is the problem with me? Okay. So of course, in him too, you will do cyclorefraction. You will measure the amount of deviation in all gazes so that you know whether it is competent or incompetent. Look out for whether the abduction is normal. Rule out 6 nerve palsy. And still you're having diplopia, you're having non-refractive esotropia. You call it acquired non-accommodative esotropia. So there are 3 types. You have the Swan type, you have the Burian-Franceschetti type, you have Balchowski. The Swan type is when there is disruption of binocularity after patching therapy. The Burian-Franceschetti type is when it is idiopathic, you don't find any cause, and Balchowski type is associated with myopia. But in these cases, you get an MRI done, see that you're not missing any acute esotropia due to a space occupying lesion in the brain, and then you can divide it into these types and treat it. How will you treat it? Again, we have Botox, You can also use Fresnel prisms, and you can go for surgery. Okay. Cyclic esotropia, it is onset is preschool years. It will be comitant and intermittent. So it will come in cycles. Okay. The fusion and binocular vision are absent or defective on the strabismic tape. Okay. You will go for the surgical treatment. In such cases, the measurement of the surgery would depend on the deviation when the patient is having strabismus. Okay. The other one is divergence insufficiency. The primary is seen in older than 50 years who are doing near work, presbyopic, go for Botox or base out prisms. Secondary, like I said before, you will have to go for an MRI, rule out space occupying lesions or increase intracranial pressure, do neuroimaging and treat accordingly. Can anyone tell me what is the difference between congenital 6-nerve palsy and DRS? How will you differentiate? Okay, so let me tell you. When a DRS is Duane's retraction syndrome. So when a Duane's case comes to you, you will see many patients who are ortho when you're looking at them. But if you try to abduct or adduct the eye, you will have classic features of Duane syndrome. There could be abduction deficiency. There would be decrease in the narrowing of the palpebral fissure on adduction. But if you see a congenital 6-nerve palsy, so there's 6-nerve palsy, the patient won't be able to abduct, and the amount of deviation. So if there's complete palsy, you will have esotropia. If there is paresis, you will have mild esotropia. So the amount of deviation will correspond to the amount of deficit in abduction in 6-nerve palsy. But in DRS, the amount of deviation won't correspond to the amount of deficit in abduction. So that is the difference. Yes, correct. Narrow palpebral fissure is correct. But in some cases, in children, you might not be able to appreciate the narrow palpebral fissure. So just remember that the amount of deviation won't correspond to the amount of deficit. Like in this person, you see almost, she is almost ortho, a bit exo, and there is hyper. But if you see the amount of deficit she is having, it is quite adduction deficit. But it was, if this was actual palsy of MR or 3rd-nerve palsy, then this deviation would have been exo, extreme exo. So DRS doesn't follow this rule. It is an exception to it. How do you treat 6-nerve palsy? You treat it by patching, by prisms, by botulinum, or by surgery. But take your time. In children, measure the by Krimsky, see that your results are reproducible, because you will have to give general anesthesia to them. So see that your result, your Krimsky is reproducible, and then go in and operate. The next is fusion maldevelopment nystagmus syndrome. It is latent nystagmus. The person will fixate in adduction, and the nystagmus will come only after you cover the eye. Just look at the nystagmus. When you cover one eye, there will be latent nystagmus. So since they will fixate in adduction, it might give you that it is esotropia. Okay, so this is fusion maldevelopment nystagmus syndrome, when the fusion is maldeveloped into when there is critical period of developing binocular vision.
I think all of us, I can speak for myself, learned a lot. That was chapter 7, esotropia.
Yes.
And so what I would say is that for the residents, they are, as Nepal, where for them it is hitting 11:15 at night. So what I would say in the last few minutes that we have, let us make it interactive with any questions that the residents may have.
Okay, so someone is asking, it is said that in sensory deviation, if the amblyopia develops for 2 years of age, it will mostly be esotropia, 2 to 4 ESO or exo, and after 4, it will be exo. Is there any specific reason for that? Actually, no, there's no specific reason for it. So it is an observation which was made by many experienced squint specialists that yes, for 2 years of age, it is mostly the sensory amblyopia goes into ESO, and as the age increases, it goes on to it more of goes to exo. So correct observation.
Dr. Sayali, in terms of exotropia, at what point
Yes.
do you consider doing an MRI?
So in exotropia, again, if there is a nerve palsy in exotropia, like third nerve palsy, or if the patient is developing acute exotropia, that time we have to go for an MRI. Okay. So again, in third nerve palsy, check out the pupil. If it is pupil sparing, pupil involving, if pupil involving, go for MRI with MRA, because the most common cause would be posterior communicating artery aneurysm near the circle of Willis. So go for MRI with MRA in pupil involving third nerve palsy. The rest you can go for just MRI. Okay.
I want to add that if, for instance, if there's a nerve palsy or a suspected nerve palsy, people should also get into the habit of trying to assess all cranial nerves, because sometimes you may pick some other cranial nerve pulses and you may just assume that it is just esotropia. So there's the need to really carefully examine and looking for nystagmus as well. And if there's a presence of that, then you should do MRI. Where you are not sure, just what I've had some children who have presented with, I mean, on the surface, it was like just a strabismus, but then carefully looking at it, maybe some nystagmus. And I think 2 or 3 of them, it turned out to be actually a suprasellar tumor in the hypothalamus and 1 or 2 in the posterior fossa. So, I mean, when there is some nystagmus or ET that I'm not too, sometimes just the intuition, I'll just go for that. And also paying attention to the optic nerve, the color of the optic nerve. So where in doubt or where not sure, always be, and especially for medical legal reason, when there's something that is a little unusual, just ask for MRI.
Thank you, Professor. And Dr. Srijana, thank you for your comment on the chat box. You mentioned that regarding the observation about the esotropia more likely before age 2, then esotropia or exotropia between 2 to 4 years of age, and then after 4 years of age, it will commonly be exo. Dr. Srijana's comment was, but it is not always true. Even in smaller children, sensory exotropia can occur. Dr. Srijana, can you unmute yourself and give us a little bit more teaching on this?
Yes, it is said, but I don't think there is any studies on this, like all the children who have sensory esotropia always, and sensory deviation always should be esotropia, because we see many children with some kind of sensory like in children with the cataracts or children with rhinoblastoma can present with exotropia as well, the smaller ones, the smaller children, less than 1 year or less than 2 years. So I think it's not always true. And the cutoff, and moreover, the cutoff age is like 2 to 4 years and 4 years. These are, I think, is not always true.
Thank you, Dr. Srijana. I also see Dr. Vera Bayu. Hello, Dr. Vera. Please, she is she recently graduated, I want to say last year, from the HCP Cure Blindness. She was a fellow in pediatric ophthalmology, doing a sandwich fellowship in multiple different areas, including Tilganga Institute of Ophthalmology in Nepal. Dr. Vera Bayu, any words of wisdom for our fellow residents as they started the journey today, but as they continue the journey into pediatric ophthalmology?
Words of advice when it comes to pediatrics, it's paying attention to detail and not rushing through the examination, being patient and trying to get as much information as you can from the child, because children are difficult they can't tell you exactly how they feel like adults. So you have to try and extract as much information as possible as you can from your examination. And I wish them all well. Thank you.
Conclude this wonderful session by thanking our wonderful faculty, Professor Vera Essuman, Dr. Sayali Mahajan, Professor Srijana, Dr. Vera Bayu for coming, Dr. Rohita, for all being with us today and being here for you. This is just the beginning, so you can feel free to communicate with them. Doctors, if you would like, you're welcome to put your email in the chat box so that they can further communicate with you and be mentored by you in the future as they choose pediatric ophthalmology for fellowship and beyond. And 2 weeks from today, we will be having our next set of chapters, so please do study hard. It is not easy. So I would even recommend feeling free to actually go back to everything that you've learned today and reread, okay? So that you can take, now when it's fresh, you're gonna get the most out of reading. Again, you've read it, now you've learned it, now you read it again and you'll never forget it.
Yes.
Yeah, right.
Right? So do that so it's solidified. Thank you, everyone.
Thank
Thank
you.
you. Thank you so much.
You.
Thank you.
Thank you.